So before performing the newborn exam, I want to make sure that the parents understand what the newborn exam is, why we do it. We want to give baby a head to toe look over, make sure that off the bat everything seems to be normal, give us that confidence both as providers and the parents, and establish a baseline for baby. So I'd want to give them something written so I can get written consent and also get verbal consent from them that they're okay with this. I'd want to wash and dry my hands. And when I come back, or if the sink's in the room, ask parents if I can place baby in the supine position, hopefully near them, and make sure that it's warm and free from drafts. I'd want to note the APGAR scores at the time of birth. So if, let's say, baby had poor color and wasn't doing well respiratory-wise, I could pay special attention to that during the newborn exam. Before I dive into it, I'd first want to look at baby. Baby's exposed. I want to look at their skin and discuss any related concerns. Parents might ask, like, why are their hands blue? Well, that's acrocyanosis. And it can be pretty normal for babies in the first day or two once they're born, as they're transitioning to breathing and supporting themselves. It's usually transitory. So to start, we can do vitals. So we can take baby's temperature, axillary temperature, so under the armpit, and normal parameters for this are 97 to 99. And we can listen to the heart rate. Typically you want to listen for a full minute to get the actual heart rate in a minute. And we want to listen in all four spots of the heart. Okay. And we want to note, is it a regular rate and rhythm? Are there any murmurs that we're hearing? Murmurs aren't always a sign that something's wrong, another transitory thing, but it's something to note, to watch as baby grows in the next few weeks. And then placing baby on their stomach. I want to listen to the respirations. I want to listen in all of the lobes of the lungs and make sure that they're clear. And move side to side to compare. And also, I want to note if they're having any difficulties with respiration. So rib retractions, nasal flaring, any grunting, and when they exhale. And I want to palpate the femoral pulses bilaterally. This is found near the groin. You could also note too if they're weak or normal or bounding, and you want to make sure that you're feeling them equally on both sides. Now moving on to measurements, we want to take baby's biparietal head circumference. This is the widest part of the head near the brow. Okay. And normal for that would be 32 to 37 centimeters. And the chest near the nipple line. And normal for that would be 30 to 35 centimeters. Then we'll do baby's length. We want to lay this under baby to get the most accurate, and making sure baby's not on a soft surface to get an accurate measurement. And normal for this would be 18 to 22 inches. Finally, we can weigh baby. So we'll get the sling ready. And hook that up. Take baby for a ride. And what's considered a normal weight for what midwives would care for, and normal in general, would be 5 pounds 8 ounces up to 8 pounds 13 ounces. So there's quite a range. Next, we can move on to assessing the head. So we want to palpate the anterior and posterior fontanelles and make sure that they're open. We also want to feel the suture lines, okay? We want to assess if there's any molding. So, what is the firmness of the head? Are the sutures overlining? Are the fontanelles slightly not closed, but when there's molding, sometimes there's overlapping, and we want to just note that, you know, the distance between them or lack of. We also want to make sure that there are no lesions on the head, and then we want to note any caput, which would be swelling, or document if there's any cephalohematoma, which would be blood that is under the skin there. Next, we can move on to the eyes. I do not know where my pen light is, and my ophthalmoscope is at clinic, so I would check for the red eye reflex with the little glass, and then I would also note the pupillary reaction to light, so it should constrict with the light. I'm also going to note if baby can track with their eyes. I want to note the size and shape of the eyes, and if they are in appropriate position. I'm going to look at the whites of the eyes, the sclera, and note if there's any yellowing, so jaundice, or hemorrhage, so like broken blood vessels from trauma during birth. I'm then going to make sure that the nose is patent, so open bilaterally on both sides, so that I can make sure that baby can breathe. Because they are obligated nose breathers, they need to be able to breathe through their nose. Next, I'm going to assess the ears, and also I would at this time mention the newborn hearing screening to the parents. Usually that's done at the first visit postpartum. I'm going to make sure that the external ear is fully formed and not like folded over or appearing abnormal. I want to make sure that there's no preauricular tags. I'm going to assess where the ear is attached, and I'm also going to assess the ear, the pinna, for firmness, so ear recoil. As baby develops in the womb, the older that they get, the more quickly the ear recoils. I'm then going to put on a glove, and I'm going to assess baby's mouth. I'm going to check on the tongue's size and position. Normally the tongue fits within the mouth. And I'm going to also assess for any lip tie, so any restriction. Lip ties aren't always a cause for concern, but some more restrictive lip ties can interfere with breastfeeding, so might assess if that needs to be snipped or not. We can also assess for any lip ties as well. And then I also want to go in and look and feel the palate to make sure that it is closed, there's no clefts. And I want to also assess that baby can effectively suck and swallow. Right. I'm going to take my glove off. Next, we will check on baby's neck. I want to feel the neck and assess it to make sure that there are no pits, masses, clefts, or webbing. All of those would be abnormal. I'm also going to assess the collarbones to ensure that they are intact, that they weren't broken. And I can also assess that baby has good range of motion. Next, I'm going to assess baby's chest. I will want to assess their breathing, that both sides are rising symmetrically. And I also want to check the breast bud formation, because that also can tell us how old baby is gestationally. What would be normal for a near or term baby would be 0.5 to 1 centimeters. So I'll just measure one of the breast buds, the pink portion of the nipple and areola. Next, we're going to move down to the abdomen. So first I want to look, what shape is baby's abdomen? Is it scaphoid, flat, or distended? What would be considered most normal would be flat. I am then going to auscultate baby's bowel sounds in all 4 quadrants. So I'm going to listen, and I want to hear clicks or gurgles in all 4. So by this point, baby should have fed. That is what is needed before doing this to hear the bowel sounds. And then I'm going to palpate the abdomen for any masses or organomegaly. We shouldn't feel anything abnormal in there. And then we will look at baby's cord stump. Now, this might be difficult to tell, but you can always take a peek at baby's cord stump to see if there's 3 vessels. The placenta should also be checked, and maybe you know from that already at this point when you're doing the newborn exam. Then we can do hips. So we'll do Ortolani and Barlow. We're assessing for any hip clicks and range of motion. It's kind of hard to do with a doll, but I then want to assess the spine. I'm going to run my fingers along it. Is it straight? We want it to be straight and complete. We'll look down by the buttocks and see if there's a dimple. If there is a dimple, that's not always a cause for concern. It's just something to note. But we do, if there is a dimple, want to visualize that it is closed. And then document if there's any tuft of hair. Next, looking at the genitalia. If this is a baby girl, we're going to assess maturation by looking to see that the labia majora covered the labia minora and most of the clitoris. And then note any discharge that we see. So if there is discharge, is it bloody, mucousy, white? It can be normal to see just a little bit of blood in like the diaper or upon assessment due to mom's hormones. And then if this is a boy, we would first assess by looking at the rugae, the folds in the scrotum. The older a baby gets gestationally, the more deep those folds in the scrotum get. Then we will also look at the penile opening, so where the urethra comes out. Where is that? Is that a normal midline at the tip position, or is it somewhere else? And then we will also palpate the testes to make sure that they are both descended. Next, looking at the anus, we want to make sure that we note that it is patent, that it is open. We want to make sure there's no fissures, and we also want to identify the position that it is midline and in a normal position. Next, looking at the extremities of the baby, so the arms, hands, legs, and feet. We want to make sure that they have 5 fingers on each hand and 5 toes on each foot, that they have proper range of motion, that the legs have symmetry, so they're of equal length, and we can also look at the leg creases too. Are they symmetrical? We can look at the hand creases. If they only have one crease, that's what's known as a simian crease, and it can be indicative of different conditions. And we want to look at the plantar creases on the feet. This helps also tell us how old baby is gestational wise. If they are full term, typically we'll see the plantar creases reaching to the bottom of the foot. We want to assess for any webbing that would be abnormal of the fingers or toes. Yeah. And then we can do baby's reflexes. So we have suck and swallow and rooting. So we can elicit the rooting by stroking the baby's cheek. They turn. If we can get our finger in there, if they want to suck on it, we can assess suck and swallow. We can also do the grasp reflexes, so palmar grasp, plantar grasp, and we can do Moro. And then we have gallant. So if we stroke the side, baby's trunk should curve that way. And then also the stepping reflex. We want to once again assess baby's skin, but for a couple of different things. Any milia, we would typically see that on the face. That's pretty normal, baby's adjusting. Same with certain rashes, milder ones that you see on some babies from time to time, just as their skin's adjusting to extrauterine life. Is there any bruising? Maybe we'll see bruising on the head. If this was a face presentation, the face may be bruised, or swelling. We're also looking for that. If it was a breech baby, you might see quite a bit of bruising on the bottom or some swelling. Again, with the color, same thing as baby pink. Any birthmarks, strawberry spots, Mongolian spots, we want to note those. Doesn't always mean that something's wrong, but noting the size, the placement, so we can note any growth that might occur. Is there any lanugo, that downy hair on baby that might tell us that, oh, baby's on the younger side, or vernix as well. Although many babies at term still have a little bit of vernix in their armpits, creases, neck. Do they have any lesions or anything of concern that we're seeing that we think, oh, that's abnormal. And then finally, the gestational age assessment, which is another tool that helps tell us how old baby is gestationally. So one thing off the bat would be baby's posture. A term baby is going to be very flexed. A younger baby is going to be with a little less tone. Baby's square window sign, which would be how far this hand folds back to the arm. The older they are, the more it will actually come back. And we have baby's arm recoil, so if we pull their arms down gently, they should pop up, back up here, the more at term they are. And same with the foot recoil. They're gonna snap back. They want to be flexed. And then we have the popliteal angle. That's the angle of the knee. So if this is a term baby, this ankle is actually going to be smaller. Their leg will be more straight the younger they are. And then we have the heel to ear. So the easier it is to do this, the younger a baby is. And head leg. So if baby's head is kind of floppy right away, the younger they are, the more tone that they have, the older they are. And the scarf sign. The more resistance they have, the older they are. It's more difficult to get their arm to go across them if they have more tone. Yeah, I think that's it. And that concludes the newborn exam.